Thank you, my professor. My scope in this presentation will be about the point of neuroprotection in patients with cardiac arrest. What is our role as neurologists in this point? First, we are involved in assessment of brain injury severity, stratifying the risk of severity, and planning a neuroprotective thermal, hemodynamic, and biochemical protocol, detecting seizures as one of the most important complications that may occur in the ICU in patients post-arrest, putting an accurate and conservative approach to prognosis of the condition, and this is one of the most important concerns of the patients in post-cardiac arrest, together with ICU staff. And also, we share in the decision-making as regards the outcome of therapy, the prognosis, the goals of care. Is it end-of-life care? Is it palliative care? Is it neuroprotective? What will happen? And also, one of the important points is to facilitate the neurocognitive assessment in the survivors, because also the neurocognitive impairment is one of the most important concerns in the patients surviving cardiac arrest. The treatment priorities, we have two important points. First, we have to decide what is the cause of the arrest and trying to prevent its reoccurrence, and it's one of the most important points that most of the cases arrest 1 and 2 and 3 times. So we should determine and try to reverse the cause of arrest. Also, the most important and the scope of my lecture is the maintaining the neuroprotective, hemodynamic, and biochemical stability for the patient. The concern here is the ischemia-reperfusion. After resuscitation, the systemic blood flow is re-established, and the damaged endothelial matrix may undergo restoration, or there may be failure of the CPR. The injured cells may pass into two pathways. Either it may go into repair or into apoptosis. The factors that determine this point are many factors: the blood flow, the degree of temperature, the oxygen saturation, the glucose level, the serum pH, occurrence of seizures or not occurring, and the underlying condition of the microcirculation. We have to stratify the risk to put a decision. This point is of poor neurological prognosis, or it may benefit from the neuroprotective measures that we will have to do. We have many factors that we are trying to measure to decide the risk. The total ischemia time, which is the time between the collapse of the patient and the return of the spontaneous circulation, which include both the no flow and low flow time. The no flow time is timing passing from the collapse to the onset of CPR, and the low flow time is the duration of the CPR itself. We also should assess the patient neurologically. We should do EEG, and we have many markers in the EEG. I'm not going to in deep details in this point, but we just, from this background, the continuity and the reactivity of the EEG, have to decide if the patient is in a mild or moderate or severe degree of brain injury, because each one of them have its own decisions in the case according to the degree of risk. I'm not going in this point because it will be the scope of the next lecture, I think. So I just want to say that we should restore the aggressive strategies of circulatory support and neuroprotective pathway in those with mild or moderate brain injury. Those with severe brain injury, we should just do intensive modes of circulatory support only if they are having markers of recovery of cortical function, and they are preferentially considered for experimental neuroprotective protocols. Also, we are, as neurologists, have the concern of seizures, which is very common complication, and it is associated with both severe brain injury and itself is a cause of secondary brain injury. So all hypoxic ischemic encephalopathy-related seizures should be treated as an emergent way, in order to protect against the secondary brain injury that may occur. The standard neuroprotective measures that we are going to deal with in a patient in a post-arrest status, we have 3 major concerns. The first is the blood flow, the second is the body temperature, and the third is the metabolic stress. What are the threats to the cerebral blood flow? The first threat is the microcirculatory failure, which has many markers, either by lab analysis or by microscopic assessment of the post-mortem studies. This failure, we should restore or we should preserve the blood flow as soon as possible to prevent capillary dropout and to prevent tissue infarction and necrosis. Also, the second risk is the effect of cardiac damage. Most of the cases, up to 50% of the cases of intra-hospital cardiac arrest occurs secondary to myocardial infarction, and this will lead to irreversible cardiac damage. And the other types of arrest may be secondary to reversible cardiac injury, like ischemia, epinephrine administration, defibrillations, and metabolic acidosis. All these points will end into cardiac damage. The cardiac damage will lead to a case of shock, global vasodilatory status, and this will be characterized by high level of inflammatory cytokines, by activated neutrophils and other inflammatory mediators. And this vasodilatory status occurs in the first 4 to 12 hours after resuscitation, and then it repeats again during the rewarming phase from the targeted temperature management, as will be mentioned. So the effect of cardiac damage is one of the most important factors that may impair the cerebral blood flow and will lead to worse prognosis. Also, hyperventilation is one of the most commonly performed techniques in postpartum patients. In post-arrest cases. Hyperventilation will lead to decreased cerebral blood flow by the effect of pH on the cerebrovascular smooth muscles, and is independently associated with worse outcome after cardiac arrest. So the aim of post-arrest care is to maintain the patient to a normal or slightly low pH to maintain or augment the cerebral blood flow. So this is the aim of ventilation, not hyperventilation. Also, the blood pressure is of significant role. Adequate perfusion pressure in the hours after resuscitation is important to prevent progression of vulnerable cortical and subcortical regions from ischemia to definite necrosis. There is no ideal number of blood pressure can be, target of blood pressure can be mentioned, but the minimum mean arterial pressure should be 65 millimeter mercury, but it is globally accepted that hypotension is associated with worse outcome than normotension, and we should avoid hypotension in post-arrest patients. Body temperature also is one of the important factors that affect and increase the risk of tissue damage in the brain after cardiac arrest. High temperature is associated with increased brain injury in both human and laboratory models. So the superiority of mild therapeutic hypothermia to no temperature management is the targeted temperature management after cardiac arrest, and we should keep the normothermic or slightly hypothermic environment in the first 24 up to 72 hours after resuscitation. They found that this target will increase the possibility of better outcome regarding the verbal commands after resuscitation in survivors of cardiac arrest. The control of blood pressure, of body temperature after resuscitation is recommended to be controlled as soon as possible, and the target between 32 up to 36 degrees for the 24 up to 72 hours after resuscitation. But we should be careful in the management of the complications of this therapy in the form of shivering, discomfort, electrolyte disturbance, decreased cardiac contractility and vascular tone, bleeding, delayed metabolism of medications, decreased gastric motility, immune suppression, and interference with the neurological prognosis. So if we adopt the temperature management protocols, it should be performed in experienced centers to prevent the temperature management complications and its adverse effects. Some data suggest that the superiority of the 35 degrees up to 36 degrees target for patients with severe shock, and we should remember that rewarming should always be performed slowly to minimize adverse consequences of the inflammatory and vasodilatory effect of rewarming process. The third concern in the neuroprotection after cardiac arrest is the metabolic stresses that may occur to the patients, and one of the most important concern is the hyperglycemia and hyperoxia, both of which augment oxidative stress and in the injured tissues and are independently associated with worse outcome. Hyperglycemia by its own, regardless of the patient is diabetic or not, is very common and very critical in post-arrest cases, because the state of arrest and CPR is one of an extreme stress response in which endogenous and exogenous catecholamines are given, so there is maximal degree of insulin resistance at the tissue level. So there is a strong independent association of hyperglycemia and poor outcome. Many of the patients should be monitored in the post-arrest state regarding the plasma glucose level, and it should be normalized in insulin even if the patient is not diabetic. Also, blood hypoxia lead to increased free oxygen radicals in the damaged tissues and worsen the neurological outcome in both animal and human models. So hyperoxia is also associated with worse ischemia and worsening outcome. There is also a risk of hypoxia. So there is a safe range of PaO2 of 80 millimeter mercury up to 300 as a reasonable range to be maintained in the patients in the ICU post-cardiac arrest. And maintenance of oxyhemoglobin saturation of 94 up to 99% after resuscitation is usually achieves this required level. The last part of our presentation about the outcome evaluation, and this is one of the important rules of neurologists in the assessment of the patient with, after cardiac arrest. Of course, hypoxic ischemic encephalopathy-related seizures are associated with higher incidence of brain injury severity and also is a cause of ongoing secondary injury, and it should be managed carefully. Patients who are comatose after cardiac arrest should have very common and we can say continuous EEG monitoring for them, if not, if applicable, at least through the process of rewarming to normal body temperature. We should know that more than 50% of the survivors of cardiac arrest have measurable neurocognitive dysfunction in the coming months after arrest, and 20 to 50% of them, if they survive the arrest, will have persistent deficits in memory, in learning, and in executive functions if assessed after 3 months, and this should be discussed with the family for the survivors. Many experts also usually delay the decision or the assessment of the cardiac arrest patient, and don't discuss with the family the prognosis and outcome after cardiac arrest after at least 72 hours after rewarming from targeted temperature management, and or 72 hours after the arrest itself. Yeah. And also, one of the most important concerns that face us when we are assessing a case of post-cardiac arrest, that the factors associated with delayed awakening after cardiac arrest. Most of the patients don't restore their, even if they have good parameters of recovery, they are not getting better in a very in the rapid expected time that we expect. We should consider in this point that patients may have renal insufficiency, patients of older age, patients with prolonged post-resuscitation shock may have prolonged time of recovery or prolonged time expected to recover. And finally, the shared decision-making is considered to be a combination of neurologist and ICU staff as regards when to declare for the relative of the patient to think about the end-of-life care for the patient after cardiac arrest. Summarizing the points, neurologists have a critical role in post-resuscitation cardiac arrest and are key participants in the treatment team from the time of first restoration of a perfusing heart rhythm throughout the establishment of rehabilitation services for the survivors. When prognosis has to be performed, a multidisciplinary meeting to exchange information and make decisions about the goals of care should be considered, and it's a primary function of the neurologist to plan for the rapid neuroprotection after cardiac arrest, including the maintenance of adequate cerebral blood flow using the high normal blood pressure targets and avoidance of hyperventilation, the maintenance of low or normal body temperature for 24 up to 72 hours after resuscitation, and the normalization of oxygenation and serum glucose level. And thank you.